Ladies and gentlemen, at this time we ask that you please take your seats. Our program is about to begin.
Good morning and welcome. I'm Andrew Dreyfus from Blue Cross Blue Shield, and this is this has just become such an extraordinary event. I said to our guest, one of our guests, Jonathan Bush, who's here for the first time, that it's like a revival meeting. And I see everyone hugging and greeting each other, or it's like a college reunion, something where we all get together and honor each other, celebrate, but think big thoughts about how we can create change. So this is a milestone event for us. We are going to take stock today on some of the work we've done. We're going to consider the road ahead and some challenges that we all face. And in the serious illness world, there are always some big challenges. You know, we like to think of ourselves in Massachusetts as an innovator, as a national leader, especially in healthcare. First state to come close to guaranteeing universal coverage. First state to really go deeply into reforming the way we pay and deliver care. A state that is facing the opioid crisis with great determination. And in partnership with all of you, we have another opportunity here to be in the vanguard. And we aspire collectively to create nothing short of transformational change in how we care for those with serious illness. It's an ambitious goal, and as you will hear today, we have a lot of work to do to achieve it. But there are some real positive signs. So last year when we came together, we had about 50 organizations that were part of our coalition. Today it's nearly 100. And if you're here for the first time and you're not part of the coalition, we'd love to have you join. All it takes is a commitment to work with us and to try to change healthcare. Just as encouraging, we're seeing significant collaboration throughout the Commonwealth, some provoked by the work of the coalition, some separate from it, but really working on advanced care planning and improving care. So for example, the coalition has been partnering with the Massachusetts eHealth Institute, the Department of Public Health, and the Executive Office of Elder Affairs around sharing of advanced directives. And I heard, though I haven't seen yet, that Secretary of Elder Affairs Alice Bonner is here today. Thank you, Alice. She's really been our champion within the Baker administration. The Conversation Ready Massachusetts Collaborative, sponsored by the Conversation Project, has been working with 20 organizations and transforming the way they think about these issues. As you'll hear shortly, all 4 medical schools in Massachusetts are now, for the first time ever, working together to strengthen the curriculum around communicating with patients and families who are dealing with serious illness. Pastor Gloria White Hammond and the Bethel AME Church is collaborating with Ariadne Labs, Atul Gawande's organization, on training faith leaders to work with congregants on advanced care planning, and more on that later as well. At our organization at Blue Cross, we're doing a number of things, but including teaming up with both the Conversation Project and Honoring Choices to offer advanced care planning training sessions to our own associates as part of our wellness program. It is part of wellness. Another sign of our progress is the show of support from our work from individuals and organizations, and by support I mean financial support. So please join me in thanking them for their generosity. Partners Healthcare, the RX Foundation, Baystate Health, Atul Gawande and Kathleen Hobson, Tufts Health Plan, Harvard Pilgrim Healthcare, the Massachusetts Medical Society, and Hebrew Senior Life. Thank you all for contributing to our work. And while we do our work here, other states around the country are looking to us for leadership. In fact, our colleagues at the Coalition to Transform Advanced Care, or CTAC, prepared a case study on our work here at the Coalition, and we recently shared that experience with other states in a webinar. From the beginning, the Coalition model has been to serve as a convener and a catalyst. Consistent with that, we gathered last November to hear from the Coalition members on what they think is most important for our work. How can the Coalition itself add value? And we heard, especially from our members, from you, about the importance of building work to engage and educate the public in a whole variety of venues and to develop a compelling message. So our summit today reflects that input we got from you. We're going to talk about public engagement based on the just completed consumer survey and a tool report on this year's results. We have a panel that's going to talk about what does it take to generate meaningful change in attitudes on major public health and social issues. And we're going to have breakout sessions. It's been a feature of every one of our summits. We're not just talking to you, we're listening and talking with you to hear your ideas about how we can translate our goals into actions for your organizations and our collective communities. And again, you'll also get an update on some of our important initiatives, including the medical and nursing schools, electronic sharing of events directives, and others. So I want to thank the coalition leadership who work so hard on this every day. I especially want to thank our small but mighty team, Richard Averbush and Anna Gosling especially, and their team at Blue Cross Blue Shield. But ultimately our work is about all of you, recognizing what you do every day and offering any support we can to make progress on this important issue. And ultimately, it's about all the people in our lives that we love and care for. And, you know, it's stunning sometimes how these things line up, but one of my closest colleagues at work has been struggling for the last week supporting her husband, who is now in residential hospice and is at the end of his life. And it's a typical story with a lot of dedicated, hardworking clinicians and family members who wanted to be there and views and love that were expressed. But there was that moment that so many of us have faced sometimes where we know things are going really well and then things take a turn. And I spoke to this colleague and I said, what you really need now is a palliative consult. And so she asked, and she was told, you don't need that. And so she asked again, and she was told again, you're not ready for that. And finally, in the third time, the palliative team came, gave her advice, and changed the course of the treatment in a way that respected both her wishes and her husband's wishes. And we all have seen how in some ways beautiful it can be, and I've seen that in my own family when things go well and when the system works. But it's hard to make it work well, and we've all had experiences where it doesn't match our values, beliefs, and expectations. And what we're about here is making sure that everyone in the state expresses their wishes and has those wishes honored in the healthcare system. So to start that, we're going to hear an interesting story about some wishes that were expressed very publicly and were honored. And to begin this conversation, I'm going to introduce my colleague and friend, Atul Gawande, who perhaps more than almost anyone in the nation has helped us change the conversation and focus our work on making sure that that we honor the values, beliefs, and preferences of patients. So Atul Gawande.
Thank you, everybody, for coming to our third annual meeting. I'm excited to introduce Jonathan Bush and have a conversation with him. Jonathan is the CEO and president of Athena Health. He co-founded the company in 1997. He took it public in 2007, and now it remains one of the health information technology industry's fastest growing companies. They've got a unique approach in the world of health IT. You don't pay up front. Coming from a system just paid $1.6 billion for our healthcare information technology. They don't pay up front. They pay a percentage of revenues, and they're in the cloud and creating an interesting way of going at it here. But you know, and to me, what's fascinating is Jonathan is always looking for the win-win. Where is the win-win for getting the right thing done? It was little known until Jonathan helped revive someone on the street in San Francisco at the JP Morgan conference, but he had gotten a start as a New Orleans EMT. He was a medic in the US Army. He was a management consultant at Booz Allen. And then he went on to start a series of birth clinics that oddly enough became Athena Health. He's also the author of Where Does It Hurt? An Entrepreneur's Guide to Fixing Healthcare. But he's also known for his famous family. His brother Billy, His uncle, he's the son of the brother of the president number 41, George H.W. Bush. He's the cousin of President number 43, George Bush. And then, of course, his aunt, Barbara, we watched go through her own experience with aging, illness, and the end of life. And she had a message she wanted us to know in the way she went about it, that she chose to undergo. She wanted people to understand she was undergoing comfort care. And we're going to talk about that. So, Jonathan, thank you for coming.
All right. Morning, everyone.
So, tell us about Barbara. I love the way you described her once. You called her, she was not a puller of punches.
Not a puller of punches. She was, we all know marriage and any really worthwhile grand institution takes a lot of work. But man, does being married to George H.W. Bush through 23 houses, 7 countries, 15 elected offices, take 5 children, 6 children, take work. And it was hard. And so she became sharp, but she became funny. And she decided to use all that hardship as an instrument of good. And she nailed it, I think, in little ways and in big, and certainly in dying well. And I love dying, because as we get better and better at protecting ourselves as a society, it's one of the things you just can't protect. We can't, there is no cross-subsidy program, there is no advanced gain-sharing initiative that protects us from that. And so therefore, is our guaranteed opportunity for humanity.
She lived to 92.
She did.
What was her life after 90 like? Like, was she struggling? Did illness come on suddenly? What was her life after 90?
Well, the parts didn't work, but the brain and the wit fired right up to the end, which is, I think, one of the great points of comfort care. So I saw her the night of the Super Bowl. Was it the Super Bowl? Yeah, the Super Bowl, where George was going to be allowed to flip the coin in Houston, and they're Houston people, and that was huge. I mean, 100,000 people, not a dry eye, and nothing, little machine and the COPD air and everything, and she's just cutting in on my relationships and how I ought to handle things, and just funny and interesting, and all the way through whatever the last year.
If I remember correctly, she was pushing the president's.
No,
incorrect.
No,
she was not.
No,
but she was walking. She was.
His little soldier guy was pushing him, which he will do, and she cannot get him in edgewise between him and the soldier guy, which might be a lesson for all of us, because he and she will have different ends. But no, she got a golf cart off to the side. But she's a very, and when we went to her funeral, and it was a fantastic, just nothing like a funeral, to take stock and sort of freeze and pull back and look down on life, and hers was no exception. I mean, just a winner. Great songs, great eulogies, great people, running completely by volunteers that came back from her staff, those 29 years ago. A lot of them look the same to me. I'm like, where have you been? Like in deep freeze? But just that lovely statement, and the fact that she planned that funeral and had been planning it for a while. Every detail, who would speak and why. Her granddaughter who struggled mightily with drug addiction and had a hard time making a go of life. She wanted to be there. Her step-granddaughter, because that's the new definition of our family. She had the presence of mind and the faculties, thanks to her comfort care, to think through all those little details and make it her final toast to us.
What was the last couple months of her life? Did she land in the hospital? What put her in the hospital? And then what were the decision points?
Well, it said COPD, so the body couldn't hold the liquid, basically, and so little by little she's gonna, drown, and so they can do lots of things to try to keep it at bay, but all of it's extremely distracting.
And so she was developing difficulty breathing above all.
Yeah, and so there's plenty of good creative medical strategy, and that panic doesn't have to be there, and she can take her time to do the work of making use of her death.
How far in advance did she say, I want as my first priority comfort care rather than length of life?
She would always say it when we heard about someone dying, or always say, "Oh, please, the body's not that special, dear. It's the soul. Let's have a drink." I think that I think she'd always been very outspoken on that. I don't. It's very hard when you're. When you're them, if you're the person attending to the former president, you don't want to be the guy who's on when some ill falls, especially the ill called death. And so there is a huge, it's a microcosm or an archetypal kind of view of what these wonderful institutions and what you wrote about so beautifully of this. My identity is miserable, and it's about pushing off that end. And to get all of that momentum reversed took her a fair amount of effort, and she is a fierce and strong soul.
Why did she? There was a certain point that it became very public. It was, I don't even know how it got out into the public conversation.
Oh, I do.
So explain that story where she said, "I want people to know that I've chosen comfort care.
Yeah.
I'm not going to the hospital." What was that moment, and why did she choose the words comfort care?
Yeah, well, she thought it was better than palliative care. And by the way, I think she's right, you guys. Palliative, I don't know what that is. It sounds like you're eating pablum instead of steak. Joy care. I mean, there's a whole notion of how many days of joy, is our measure of success, not how many days of pulse. And she thought it just sounded better. And like I said, I think it does.
And what was the moment that she decided? Was there a moment when she put out a press release or something? How did we learn about it?
I don't know. Jean Becker, they've got a staff there, and I don't know which, but what I know is that all of her days when she was awake, all of her time was with someone doing something good. Reading Psalms with Neil, we would FaceTime, with her, and different people could be on FaceTime, and cracking jokes. George in the back, don't get out the harps yet. She's not dead. It was a great quote when she took a nap. And another one, Marvin came in and she was taking a nap, and he looked, my cousin, and she goes, "No, not yet."
So she made sure the docs
She did.
that would have put her in the hospital, do everything, were
She had great control over herself. She did not have control over where she lived, her schedule and her mouth were her entire life, and her children, but where her sort of bully pulpit was her purpose in her mind. And so, as she lived her life, she was the one holding the AIDS babies when everyone thought AIDS was contagious and we knew it wasn't. And that was what she could do. She couldn't launch an initiative in a law or but she could go in the hospital and hold the babies and hug the men and just kind of put a pin in that. And this is just a perfect example of the same idea. What can I do with my me as I move around with a lot more attention than most people get to put a pin in something that's a little off?
So then, the day after her funeral,
Yep.
we discover that President George H.W. was admitted to the ICU
Yep.
with sepsis.
Yep.
And suddenly you had another family member
Yeah.
who was ill.
Mm-hmm.
How's he doing?
Well, I went to Kennebunkport to say goodbye to Uncle George. I think it was 2.5 years ago, 3. I thought that's it, and you get a little tapped out or a little distant. People get a little older, and I went to say goodbye. I said, you've been great. You've been the best uncle a guy could ever have. And he said, "Isn't it amazing how oceans and fires, you can just keep looking at them?" And I thought, yep, this is a good goodbye. 2 years later, here he is rolling around, so what do I know? But he's in a different place. He's a very agreeable guy. He works by committee. He always takes everyone's advice. He's used to being listened to, so it's easier. Barr had to be a little more outspoken off on the side. But I think it's very hard. I think that dying well as an expression of our humanity when we, with the best of intentions, kind of neutralize people's willpower with lots of safety nets and cross-subsidizing of things that go wrong, which is brilliant and a miracle of modern society. It's like a muscle. It takes working out to be ready. I loved Andrew's because you're not ready. I'm ready. Ready is now and refreshed regularly, partly because it takes a huge amount of willpower to overcome a wonderful humanity that wants to keep life alive that will be pushing against you, and partly because it's just a wonderful opportunity to express our humanity, how we die, I think.
So the president's still in the hospital, is that right? He's out of the ICU.
Yeah, in and out.
He's in and out.
Yeah.
And the day after the funeral, he's arrived in the ICU. You don't know how things are going to go.
Right.
And his healthcare proxy, we talked about this, was Barbara Bush.
Yeah.
And so you needed to have a new conversation about who is going to make decisions when he can't. And do you have any idea how has the family managed that?
I don't. I wish I did.
Yeah.
I feel like horning in, but with George, you don't know whether it's helpful or not helpful to horn in. There's so many people who all mean so well. It was easier when he was running for running for president in 1976, and no one gave a crap. He was like, "Come on with me," I was 12 or something. But now there's just so much, and I think this is another metaphor, kind of, when people are in that hospital and they're surrounded by these pros, you feel a little sheepish, kind of horning in with something that's based in just your gut about humanity, and
I think that's really an interesting difference, right? Barbara Bush had to fight her way to be heard.
Yep.
And so she made clear what her wishes were.
Yep.
And the president is used to having people just know what mattered to him, and therefore no one has, it's exactly the situation you be in. You're in the hospital, and it's hard to say who's going to now make the decisions, how is this going to happen, and what really matters here when that outspoken person who took care of that for everybody is off the scene now.
Yep.
And I can imagine it continues to be difficult for the family.
Yeah.
One of the things I want to bring in is Athena Health and its role.
Great.
So we did an experiment at the Dana-Farber Cancer Institute where, in a place that sees very sick people, Susan Block had led work that found that only 40% had the decision maker for patients named. So only 40% had a healthcare agent or a healthcare proxy that they had formally named. And they created a default, and it took work to put it in the workflow, that when people come in, that they would confirm that they have their healthcare proxy and that we had it. Or if they didn't, they would either sign that they didn't want to have it, but it was not the default was you were naming somebody, and if you didn't want to, you wouldn't name them. And it got us to over 90%.
Yep.
Now you have a healthcare information system that could do that for people. And one of the things that you'll see from the survey data that I'll show later is, the majority of people don't have these conversations. Clinicians aren't having them. The proxies aren't. Even the first basic one, who's going to make a decision and do they know your wishes for care? That hasn't been done. And that we could make that a default. At the same time, it's very clear from the survey data, there isn't a market demand for this.
Right.
So
Although there is a market benefit.
There's a market benefit.
I mean,
so how do you?
We can't afford our health care, and if everybody signed these, we could. So.
Well, say more about that, because how do you prioritize what you would build into your system, and whether you would put this kind of function into place versus not? You have how many clinicians and patients on your system? 114,000
providers. There's 105 million records, and it's about 13% of visits to the doctor in the United States. But we are a we're a courtier, right? We are only there. We don't own the hospital or the doctor. We are there at their day-to-day pleasure. And so every time we pop up a rule, the doctor has to be, or the staff have to be happy that we stopped them with a bureaucratic pop-up enough that they'll stay and not turn off the network. One of the things Andrew did, which I love, is a year and a half ago, paid for a session, a counseling session, and you don't have to be sick or dying to get it. And I think that's brilliant, because I think it's a great thing to talk about early in life, or at least at midlife. And now we can pop it up and say, by the way, $50 if you talk about this screen. And if we say that, we get to pop it up. If we said, we look down our nose at the doctor who's paying us and said, you really ought to do this differently, we'll be in the Alumni Association pretty quick. So we have to be careful to be aligned, but there are big problem with healthcare is because we cross-subsidize it in so many ways, it sort of gets fused like a giant tectonic plate, and where we're actually individuals, it's hard to move. I mean, Ariadne to me is sort of like, almost like those Maoist guys with the little red books running along saying, wait a minute, maybe you should think about this differently as they march along, because there is no, or there are not as many as there should be, market mechanisms for allowing those better ideas to gravitate. In this case, signing these things and setting up your plan in advance is an incredible bargain for the healthcare system, because it's vastly less expensive to live longer and die well with more days of joy than it is to die alone, in agony with tubes in your parts.
Well, so I think it's one of the things we're finding at Ariadne. At the end of the day, you're having to get a coalition like this together that can align all of the parts,
Yep.
but it is in the beginning, it's getting all of the pieces to begin to align around.
Yep.
Boy, you can have better outcomes of care, less suffering, often less costs,
Yeah.
and more time at home
Yeah.
for the things that matter. So
And the more, I would think you guys be interested in sort of unfusing the joints of the healthcare system. One of the things there's a health assessment you can get with Blue Cross and other plans, and if you do go to the gym or whatever, you get a discount on your plan. To me, that makes all the sense in the world. Unfortunately, Medicare doesn't offer such a discount where it matters most, but they should. And I hope everybody signs up for a Medicare Advantage plan of some kind where those kinds of things are possible, because it just makes all the sense in the world to get some of that money to your grandkids instead of to the wonderful ventilator team, who are great, and we want them, but not when we don't.
So, which brings up the last line of question I have. I often tell the story of the patient who said, that minimum quality of life they would find acceptable if they could eat chocolate ice cream and watch football on television, that would be good enough for them. Right? And if they couldn't, we'll let them go.
Yeah.
So what's the minimum quality of life you would find acceptable?
My plan. I've planned my funeral so much, but I've never planned my letting go. That's a really interesting question. In general, I'm for a guy who's given his entire life to helping doctors be doctors, I'd rather have doctors as friends. I lean more on the personal autonomy. Mm-hmm. I feel like at 49, I've had a fantastic life. I don't feel like 50 or 70 or 90 or any particular age is that important to me.
But
maybe it's because I'm not looking at the light.
If suddenly you had an illness or a terrible accident,
yeah.
Like my dad, when we talked about it, minimum quality of life, you heard it said football on television, chocolate ice cream. No way that's good enough for him. For him, it was that could he go to work and still be a surgeon? And then when that turned out to go away, he's like, well, it turns out I still like life.
Yeah.
And then he found that what he liked about life was being connected to people.
Yeah.
And that, in fact, is what he loved in medicine, having people he could talk to, sit around the dinner table and share a meal. And he had a brain tumor, and so as the brain tumor advanced, that stuck.
Yeah.
He didn't want a feeding tube because he wanted to enjoy food and want to enjoy conversation, and that was his goal. So how about
like
you?
Debate. I'm, as some of you may know, I like conflict, and as long as I can be in loving debate, I think I'd like to be around.
As long as you
as
can
I'm
battle.
checked out, yeah. Even if it's a little tiny battle, you're wrong.
That's how we'll know.
Conflict.
If you stop punching back, let you go.
Let me go. At sea.
Jonathan, thank you for giving us your time, and thank you for all you're doing.
Thank you, guys. Keep going.
Well, there's a lot in there, and I think there's that last part is kind of the part that we're still all working our way through. When we put up our mission that got us all started here, the core of it is that we're trying to ensure that healthcare for everyone in Massachusetts is in accordance with their goals, their values, and their preferences at all stages of their life and in all steps of their care. And it comes down to that very still personal question that we think we have asked. What are you willing to sacrifice? What are you not willing to sacrifice for the sake of more time? What's the minimum quality of life that you would find acceptable? And does your family know that? Do the people around you and your caregivers, do they know what matters to you? I think what's fascinating about Barbara Bush's story is she was so clear, and she was so clear from early on. And she had to be, by the nature of her life the whole way, is what I heard coming across there. That the course of her life required her to fight for what mattered and decide on what doesn't, and value that. And ironically, the president's own life is one that, because people surround him, you don't necessarily end up in the same situation of being clear who's now going to make the decisions, and do they know what is going to really matter? Well, in our work on advancing that mission, we'd spelled out 3 years ago. We launched in 2016, had this meeting, and had a survey of the entire state that had helped us understand what the nature of this problem was. And what I remember and sticks in my mind from that survey, as I come up to telling you what this year's survey shows, were two key things. One was that the vast majority of the Commonwealth, some 95%, felt that these discussions are ones that clinicians should be having with patients. And that's important because it was only 5 years ago we were still in a fight over whether that idea was a death panel or not. And so I just want to underscore what a different place we've come to. People were nervous about gathering in rooms to say that I want people to have this conversation. You couldn't get politicians, you couldn't get a corporate CEO to come and have this discussion. So I just want to emphasize how far we've come in the culture so far. But at the same time, the other thing that I remember from 2 years ago was that among people who had a hospitalization in the last year for a serious medical condition, only 25% had had that conversation with a clinician. We're going to walk through a little bit about what we have seen now as we came back and did that statewide survey again. While all of you have been doing your work, and while many changes have been going on nationally that we hoped would be pushing in the right direction. And there are many ways to think about how we would predict what would happen in this year's data. One way would be to say, this is such a huge boulder, it's impossible we will see any kind of change. It's too early. And I think it's important that we nonetheless have a set of measures so we understand where we are. Are we losing ground? Are we holding steady? But there was always that glimmer of hope, though, that it feels like something is changing. And so how do we know? Well, a huge thanks to Melissa Clark and her team at UMass, Anna Gosline and her team at Blue Cross Blue Shield, and the funding of Blue Cross Blue Shield and the RX Foundation to make the research possible. But we have fielded a survey. I'm not going to show you all of the methodology here, except to say it was 1,500 people caught by landline and cell across the state as the main way in which we've been carrying out the survey, and that's enough people to be able to pick up whether you're making changes or not. And here is the really cool thing, is that we are starting to see change. What we saw was that when it comes to how many respondents said that their dying loved ones' wishes were followed and honored by their care providers, we saw a significant increase from 58% in 2016 to 71% in 2018. And we saw a trend in reporting that care quality for loved ones that people had observed in the last year to have experienced the end of life, that the care quality had gone up, not fully statistically significant, but in the right direction to 60%. And that is, I think, a huge accomplishment. I don't think the coalition alone can take credit for it. There are forces underway that are important. But this is a state where all of you have been contributing to turning the tide and changing the way that we regard this line of work, have made it acceptable and empowered people to behave the way Barbara Bush did, and to be able to say, here's what matters to me, and then ask that it be honored. The data shows, however, we've got a very long way to go. For one, there's still 30% who say that people's wishes were not being followed as they came to the end of life. But furthermore, there's some underlying indicators that show us about where the gaps still are. I want to say, though, that the data is also showing us how important these conversations continue to be. When the healthcare team has talked to a loved one about their wishes for care as they came to the end of life, their wishes were honored 92% of the time. That's what people are reporting. 92%. Their wishes were very much honored. And not surprisingly, if you never ask, it's more or less random. It's a flip of the coin whether people are going to have their wishes honored or not. So these are meaningful and powerful to people. Furthermore, the extent to which the loved one has a discussion with their healthcare team about their wishes for their care before they've come to the end of life has a striking effect on the quality of the care that people report receiving. So it's not just whether their wishes were honored. Did they rate the quality of the care excellent or very good? And it was 73%, which was that rated it that way in the worst, for many people, the worst experience in their family life they've had. And it was significantly higher than the likelihood when there was no discussion at all. Now, the challenge still is, I said, it makes a difference if we have this conversation. The left-hand donut gets a better picture than the right-hand donut. But that left-hand donut that had this conversation is still a tiny percentage of our population. In 2016, it was 15%. It's still right around there for people having, all Massachusetts residents, having a conversation with a healthcare provider about their end-of-life care wishes, and for people who've had a hospitalization or a serious medical issue under care in the last year, we're still at basically about a quarter having this conversation. And then the final one is that among participants who had no serious health condition, that we also have had low rates with no real budge. When we look at the percentage who have had a completion of a proxy form, have been able to name their healthcare agent, we're still not even at the 50% level yet. No significant difference from 2016. And I know a ton of you are working hard on this. We still have relatively high rates of people talking to their agent about their wishes when they've named who their healthcare agent is. And we're at about half, being unchanged, who've shared their healthcare proxy form when they've had it with their doctor. This is a busy slide, but it confirms what we saw in 2016, which is striking demographic differences in the likelihood of having these conversations. Older, female, white, non-Hispanic, married participants have the highest likelihood of having these conversations. High school educated only, white male or minority have the lowest rates. These are the groups who we are least likely to reach, and that hasn't changed. This was the first year that we were able to get national data, and I think it's a reflection of the coalition's impact, that they're now, Kaiser Family Foundation in the last year fielded a similar survey, and we then used their survey to this year ask questions in a nearly identical way with the way that they asked it in their survey, and so we could begin to make some national comparisons. We think of ourselves as having the best healthcare in the country and as being a place that is more pioneering than anywhere else. We're a state that has a higher marriage rate than most states in the country, that has a higher education rate, and has better economic well-being than most states. But in this, we do not stand out from the rest of the country, which surprised me. It was a little disappointing that we are more or less identical with the rest of the country. There's a slightly higher likelihood that in Massachusetts that we would have a healthcare provider, a conversation with a healthcare provider about who's making decisions, but it was slightly lower that, that there is a conversation with a healthcare provider about wishes for medical care among people with serious illness. I think these are mostly noise from looking at lots of numbers, and that we're more or less where the rest of the country is so far. When we put the picture together, we see that discussions with doctors, discussions with loved ones, and the next slide, proxy completion, is the same as around the country. We still have to make that rare conversation happen, and in order to make that rare conversation happen, the data is you have to be Barbara Bush. You, the patient, are the primary person who initiates the conversation happening. It is not the clinical system. And it's no surprise then that what you hear was, from Jonathan, was a difference between this conversation when it came to Barbara Bush than it came to George H.W. Bush. Reflects the demographics, reflects the way our institutions work, and whether they are training and supporting people to have these conversations. We used a new measure of defining who is seriously ill to include people who report themselves to be in poor health, which is similar to a way that the Kaiser survey had done it as well. And there too, where you have people who are in poor health and have a serious medical condition, 65% have not had a conversation about their goals of care, not just their end of life, but about what their goals of care are for their quality of life and not just their quantity of life. It's a sign of this still being a long way to go. Why? Why is it a long way to go? And the survey data shows us that, that it's still both providers and patients who are reluctant. Many people saying, well, I'm still healthy and don't need one yet, that will trust the healthcare team to either make a decision or make the conversation happen. And that I know I need to, but haven't gotten around to it. It's the story Ellen Goodman has said, it's too soon until it's too late. And that's still the story that people describe. So should we be discouraged? How do we think about the progress that we have made and the hill that's still there to climb? I had a chance to see a presentation from Bridgespan, which is a organization that works with nonprofits and are increasingly focused on solutions that help nonprofits and social movements be able to figure out how to create change at large scale. And this was a study that they had done that they published in, of all places, that important journal of social change, the Harvard Business Review, on 15 case studies of what they called audacious change. Change that involved transforming entire states or entire countries. And it included the anti-apartheid movement, child safety seats, CPR, 911 becoming a national program touching everybody, the polio eradication program, Sesame Street, the stop smoking progress that has been made, motorcycle helmet adoption going from 20% of people who were driving motorcycles in Vietnam to 95% in Vietnam. How did people do these things? And there were three things that struck me about the report on from their study. Number one was how long change took. This is their graph of what they found, that the median time to create public libraries in every community, CPR, move tobacco control to actually turn the smoking rates around, hospice and palliative care going from virtually unavailable to being universally available, though not always tapped into. The median was 45 years. 45 years. And the second thing was they were able to map out the cycle of change. What happened over those 45 years? What was involved in being able to drive change at a broad level? And it starts, although it's a whole cycle that goes round and around, it starts with building a shared understanding of the problem and its ecosystem. The way I would describe that, take tobacco control, for example. There was 20 years where there were no coalitions with a shared understanding of the problem that they had. They didn't have people in a room. Then they got the people in the room, and then they spent, so from the moment that it launches a movement to actually getting people in the room, and then deciding on whether the problem was tobacco control took about 20 years. Because the dominant focus, the shared understanding of the problem was, we have to get people to quit smoking. And it took 20 years to discover that wasn't going to work. It's so incredibly addictive that getting people to quit smoking after they've started wasn't going to work. And what you needed to do was tobacco control. You needed to stop tobacco supply and get it out of the hands, especially of young people. And then it was a decade or more of experimenting with what are the levers, stage two, what are the winnable milestones and the compelling message that could win this over. And it gradually discovered, as people come to call the Bloomberg checklist, so to speak, which is you got to tax the hell out of tobacco. You have to enforce that underage tobacco sales would be penalized heavily and actually enforced. That you would have bans on public smoking, and you'd have a public ad campaign with messages that people have learned are the most effective messages to put out. And the result is when you deploy that, now go city by city to other countries, you cut it by half. You can cut smoking by half and have changed it from, it's still a huge problem in the United States, but it's no longer our biggest cause of cardiac disease. And the result is you see states like Massachusetts who have very low smoking rates and are starting to get our blood pressure rates under control. Now cardiac disease is no longer the #1 killer. It's possible to make these kinds of changes. The next part of it is that you have to design approaches that will work at massive scale. You had to simplify and simplify and simplify. And then you have to drive, not assume demand. And then you course correct and you go back around again. And that is the crucial cycle. Our cycle, we've defined the problem to solve. The debate about what has to happen around end-of-life care has been going on for a long time. And we've been through a very divisive decade or more about what should happen. But I think we've become clearer that the discussion isn't about getting people to stop fighting and give up. I love Jonathan's statement. It's joy care. What are we fighting for? What is your joy? What is the reason you want to be alive? What is the joy that we want to make sure we never sacrifice along the way? And understanding that for him, it's getting to punch back. For someone else, it's football on television and chocolate ice cream. What is your joy? Is the problem we have to solve. And that we've gathered around a shared understanding of that problem. That people have priorities in their life besides just living longer. We have to ask people what those goals and priorities are, what those joys are. And then we have to align our care to honor and achieve those goals. We haven't gotten to the full set of winnable milestones. The 3-4 things that really turn the tide. But we're experimenting and we're learning. There's a set of public messages that organizations like the Conversation Project is helping drive and helping learn and helping tap into. How do we get people to understand this? How do we make it understood not only in the way that the demographic that's currently latching onto it understands, but that we are also getting to the high school educated only population, the male population, the minority population. And those messages we're still crafting, testing, working on. A second component you'll hear about today is we've gotten the medical schools to define that they will teach these basic skills so that the future generation is not one that's going to wait for the patient to demand to have this conversation, but have learned how to make it a routine part of care to ask what your priorities and goals are and then be able to match care to those needs. And you'll hear a presentation from that team about what is involved there. So we are putting these milestones together. We're in the first couple of innings of this game, and we see that we've had people on base, we've scored a run or two, and we got the whole game still to go. The last thing I'd say is that there was a third lesson that came out of the work that Bridgespan has done that I thought was really powerful and fascinating, and it was understanding the role of what they called a field catalyst, the role of often hidden coalitions, whether it was the coalition behind gay marriage or the coalition that is running the campaign to eradicate polio. You can't find it on any one website. It's a coalition for the eradication of polio that includes the WHO providing surveillance and discoveries of the key tools that every country needs. It's the Gates Foundation and Rotary putting funding in, Rotary supplying on-the-ground people when you have rumors and false messages that make people distrust the polio campaigners, that commitments of governments coming in behind UNICEF supplying the vaccine and keeping the cost cheap. There is no one website for the polio eradication campaign, and yet they all meet together every year in a meeting like this, set their goals, measure how far they've come, how far they haven't come, and yes, it's been 25 years of their work at that, but they went from hundreds of thousands paralyzed per year around the world, millions of people infected with polio, to one where we're down to now fewer than 100 cases in the entire world. And we're desperately working to drive that to the end point. This is the field catalyst. This is the coalition that is making it happen. We're not going away. We're going to be here for a long time to come. And we're going to keep describing the milestones that we've discovered that move the needle along. And that's what the day today will be. So thank you for gathering around this work. Thank you for the progress you've contributed to. It's a big deal that we could go from just over half of the population to nearly 3/4 of the population saying that when people came to the end of life, we were honoring their wishes. But we still have the basic infrastructure and building blocks that you're going to help us build along the way. So thank you. One of those people trying to create milestones, those winnable milestones, that pathway that institutions can follow, is Dr. Vicki Jackson, the head of palliative care at the Mass General Hospital, co-director of the Harvard Medical School Center for Palliative Care, and a longtime partner in this work, and one who's taught me so much. So, Vicki, thank you for coming.
Thank you so much, Atul. I just am so moved by seeing everyone who is here and really thinking about the coalition and the work that can be done. It's really such a powerful catalyst driving change in how we help patients and families and caregivers respond to the impact of serious illness. Unless you have been through it, you don't know how difficult this is, and we have an opportunity to be able to do something pretty special. I think that not every state has the ability to be able to do. I am part of a healthcare organization called Partners, and we are very, very committed to this work and feel that the ability to work with the coalition and to be a partner is something that feels really critical to our mission. And you know, when we think about this, I think this work is about having a healthcare system that actually responds to what matters most to people and can make that something that can be part of everyday care for patients and families. Because you know, the stakes are high and we need to get it right, and we often don't have a second chance. And so the idea that we can come together today to do this kind of work, and as Atul is saying, in an ongoing way, this is going to be a marathon, not a sprint. But we can do this together, and I think have a group of individuals as well as organizations in the state to be able to do this. And so I get the opportunity now to introduce one of these individuals who's been a real driving force, excuse me, in this change, Maureen Bisignano. Maureen has worked for years in this area, is the President Emerita and Senior Fellow of the Institute for Healthcare Improvement, and has served as IHI's President and CEO for 5 years after working as an Executive Vice President and COO for 15 years. She's a prominent authority nationally and worldwide in improving healthcare systems, and has been recognized for this work by her elected membership to the National Academy of Medicine. Maureen advises leaders across the world and is a frequent speaker in healthcare conferences on quality improvement. And most importantly, related to this work that we're doing today, co-chairs along with Atul the Massachusetts Coalition for Serious Illness. And so please join me in welcoming Maureen.
Thank you, Vicki, and thanks to Partners for your fantastic support of all of our work together. I'm so excited to be here with you all for our third meeting. I'm filled today, I'll tell you, with anticipation and gratitude. The anticipation is that we can actually build on what Atul was saying this morning and go faster, because the need is so urgent. And I think together that we can. You'll get an opportunity to come together and think about how we can do the work that we all want to do. And I'm hoping that we can do it more quickly than 45 years. So let's see what we can accomplish today. The coalition, as you know, has done research, as Atul was saying, and we've also convened people, brought people together for the energy and the momentum that we can build. But we also have a whole lot of other activities that I want to share with you this morning. You're going to hear 2 case studies, and then I'll share with you some of the other progress that we've made. But together, I see that we've got the challenges to come to hear people's wishes, not only for the end of life, but during an episode of serious illness, to find out what matters to them, to find out what's important. I loved it when Jonathan said, this is our guaranteed opportunity for humanity. And I think that's what excites me about being here together, a guaranteed opportunity for humanity. So I'm going to have the 2 brief summaries. The first is I'm going to introduce Lawrence Stuntz, and Lawrence is the director of the Mass eHealth Coalition. The reason this is so important is that we have found so often that someone may express their wishes, but it's really difficult to find it in an electronic record. I had the same experience when I visited my primary care physician recently, and I said to her, I want to talk with you about my wishes at the end of life. And her response was, no, you're fine. And I said, no, it's not that. I really want to tell you what matters to me. And she said, no, you're fine. And then I kept pushing her and saying, you know, in a short period of time, Atul and I are going to be getting up, and I want to be able to say, I'm one of those people that have my wishes in the electronic record. And so she turned the computer around and we had the conversation. It wasn't hard to have the conversation. It was hard for her to find the page to put it into. So I think the work that Lawrence is going to be describing for us this morning is really going to be critical. And then second, you'll hear from Dr. Jen Reedy. Jen is the chief of the Division of Palliative Care Medicine at UMass Memorial and also at the UMass Medical School. And the work in getting physicians to understand how to have that conversation, to make my physician more at ease to sit and talk with me when I'm not in a serious illness conversation is critical. And I had the wonderful opportunity to see Jen's work recently and to look at how she's brought together medical schools from across the state to begin to build this curriculum. So we've got lots of wonderful work to do this morning, and here I want to introduce Lawrence first.
Thanks, Maureen, and thanks to all of you for showing up. It's remarkable, you know, how the room stays full over this is the third time that we've all gotten together in the room. I think is just as full as when we started. So obviously, there's a ton of energy here. As Maureen mentioned, I'm the director of the Massachusetts eHealth Institute, which is a state agency focused on helping supporting electronic technology in healthcare. And so we're the people who inflicted electronic health records on you. I don't know whether that's excellent, but one of the key advantages I think that we've gotten to in Massachusetts is the vast majority of all patient visits are now captured. The data about them is captured electronically, and we're starting to be able to share that. And so one of our efforts over the past year has really been about, okay, how can we leverage that infrastructure to support the sharing of advanced care plans? So we, last summer, brought together a group of stakeholders to advise on how we might do this. We did a landscape analysis of other states who have started to work on sharing of electronic advanced care plans. We did an RFI with technology providers. I think the technology in this is going to be, I don't want to say it's the easy part, but it's definitely relatively simple and totally insufficient for the actual sharing of end-of-life care plans or advanced care plans. And so the stakeholder group and what we've determined is that this should be as we're going to roll this sort of thing out, we need to do this in coordination with this large coalition of folks who are working on the transition of the medical orders for life-sustaining treatment, the MOLST form, and a statewide electronic advanced care plans, and sharing those should be done in conjunction with the rollout of an update to the MOLST form. And so, we've brought together folks. We will continue to work with folks, and folks like Ellen DePaula and Jen Reedy and others who are figuring out how do we roll out electronic advanced care plans across the state. So we're really excited to work with all of you. If you go to mihai.masstech.org, you can see sort of a history of the work that we've done and the work that we will be doing. We're looking forward to talking with folks across the spectrum and understanding what will make electronic sharing of advanced care plans and MOLST forms most effective as we roll it out here. So thank you very much, and I'd like to invite Jen Reedy up to talk about her work with the medical schools.
Good morning, everyone. It's good to see you. So I had the pleasure of working with some wonderful colleagues at our 4 medical schools here in Massachusetts. And we've shared a common goal of trying to advance palliative care in undergraduate medical education. And we were brought together first by Atul and Dr. Harris Berman, who's the dean of the Tufts University School of Medicine. And we started as a faculty group and medical school leadership, to sit together and listen to each other, to learn more about each other's existing curriculum, which is quite substantial and impressive. But we made a commitment to each other to raise the bar and to motivate each other to do better as a learning community going forward, and with the thought that as peer mentors, we could accelerate change faster at each of our individual schools. So we had to start somewhere, and we decided to focus on trying to improve medical students' foundational knowledge and skills in serious illness communication. And we put together a Crackerjack working group who met monthly to develop a set of shared competencies. And this was adapted from some national consensus work that was done by Dr. Kristen Schaefer and colleagues. And then we took those competencies and brought it back to the full group, who unanimously have approved them, and now they're ready for implementation. So let me show you the competencies, if I can figure this out. Whoops. Forgive me, I'm having here we go. All right. So we've developed 5 competencies around serious illness communication. So the first competency helps students figure out where to start, which is what does the patient and family understand about their illness, and then pushes them to dig deeper to understand the values, goals, and priorities that should be guiding the medical plan of care. Competency number 2, we want students to be able to sit with and acknowledge strong emotion, and to experience that as a way to more effectively connect with people, comfort them, provide support as they're facing different serious decisions. Competency number 3 is about having students recognize that there's a cognitive framework for having these discussions. So as they watch other clinicians talk with patients about difficult news, prognosis, discussing treatment options, goals of care, resuscitation preferences, that they can see that framework. And then next, apply that framework in skills practice with standardized patients and in some role play scenarios that will prepare them as they're soon-to-be interns and residents having these conversations. Competency 4, I think, is really exciting and groundbreaking in that all of us that work in healthcare, we know the rewards, but also the stress, the vulnerability, the sadness that accompanies being fully present with another person's suffering. And imagine if we could equip medical students early in their careers with skills and strategies for coping with stress and helping promote resiliency, how we might affect rates of burnout in healthcare. And then finally, competency number 5, we want students to be able to clearly describe palliative care and hospice as related but very distinct fields of healthcare. And frankly, I would be thrilled if my attending colleagues could reliably do that at my own health system now. So armed with this information, our future doctors will be great change agents and ambassadors for palliative care as the standard of care for people with serious illness. So those are the competencies. And so now we kind of stand on the threshold of implementing them. Hopefully we're at stage 1 of what Atul showed us of the audacious framework. And now we are working on developing a baseline assessment of where are our students right now in terms of their experiences and their attitudes about serious illness communication, and to continue to reevaluate that over time. We're also working on some ideas as a learning community for shared faculty development going forward. So stay tuned about that. So I would like to recognize all the folks that have been involved in this very big effort, and so I would like to read your the names, and if you're here, please stand up, but please hold your raucous applause until the end, till everyone is standing. So from Boston University School of Medicine, Priya Garg, Megan Young, Hollis Day, Suzanne Mitchell, and from Harvard Medical School, Edward Hundert, Vicki Jackson, James Tulsky, Kristen Schaefer, Leah Rosenberg, April Zem. From Tufts University School of Medicine, Scott Epstein, Julia Ragland, Wayne Saltzman, Isabella Stumpf, Tamara Vassell, and from UMass, Melissa Fisher, Melissa Clark, who could be with us today, and then from the coalition, keeping us together, we couldn't have done it without you, Atul Gawande, Anna Gosling, Richard Averbush, and Maureen Bizignano. So let's give a round of applause for all of these folks who are making this happen. And before I finish, are there medical students in the room? I know there are some from UMass, at least. Can you please stand up if you're a medical student? All right. So keep standing for a sec. So we created these competencies for you to serve you better in your medical education and your professional growth. And we want you to hold us accountable going forward and help us gain support for making these changes, because curricular reform is a challenge, so we need your support. So we need you to help us drive and sustain change. And thank you for being here today. So we'll finish up by watching some stories of medical students from each school talking about why this initiative matters. And thank you to Richard Averbush and the team for putting together this video testimonial. Thank you.
The reality is, the way that our system is right now, physicians don't have time to have these conversations.
The body, as we all know, does die and does get sick, and we have to, I think, be experts in shepherding our patients through that process.
As much as we would love to, we cannot solve every problem and fix everything.
Perhaps the other area that really deserves space is how to have serious illness conversations.
As a student who's interested in palliative care, you have to go searching for yourself. My first year, I was part of the geriatrics interest group, and we have an elective where we're paired up with a patient who's over 70, and I remember my patient very fondly. She's a 95-year-old when I met her at the time. Very independent. We actually made a home visit. I remember sitting on her couch and her offering us tea and cookies and having this long conversation with her. And I don't think a lot of physicians have the time to have these conversations in the office, which is why I admired this particular geriatrician so much. I think I learned from her just like taking in the whole picture of the patient. Like, yes, she's 95 years old, but she can make all these decisions still.
I did a service learning project at a nursing home. So the first person I got to know at the nursing home, her name was Millie. And at one point, maybe a couple meetings in, I asked her about, trying to kind of lift her spirits, I asked her about music. What's her favorite type of music? And all of a sudden she just lit up. So the next time I got her, some headphones and I plugged them into my computer and I just played some songs for her. And what I found in that interaction was that was really important to her. And the next person that I got to know, I thought, I know how to do this. His name was Ricardo, and he was a man who had a lot of family in the area. And when I mentioned music, he said, "Oh no, I already have an MP3. I'm fine. I don't need any more music." And I just want to talk. He was able to talk to me about end of life because I was able to listen and encourage him, but I wasn't a family member because that was too difficult for them. For Millie, it was music. It was just the simple pleasure of having music around. I think for Ricardo, it was something deeper.
A woman, I'll call her Miss E. She was suffering from ALS, Lou Gehrig's disease. This was a really meaningful patient for me to care for because, one, it was the first patient for whom I led a family meeting. It was the first patient I was there for at the time when we called her death. The complex thing about this relationship, especially for the family meeting, was that, one, she had, I think, tens of thousands of dollars of gambling debt owed to her family, and two, her family was not so accepting of her same-sex relationship. You go in there as an aspiring palliative care doc or anyone in the medical team, and there's a slight temptation of wanting to, I don't know, just fix it, right? And lead to a neat resolution of all of this interpersonal conflict before Miss E passes away.
I was in the ICU, and there was a patient who had been there for weeks, and the residents switch every 2 or 3 weeks services, and the attending switch every week, and I happened to be the person that was on for a month. And so from the time of admission to the time of discharge, I was the person. I was the person that when we did make the decision to move to comfort measure, that the daughter of the patient hugged, because I'd been there. And that patient passed only days later, and I stood in her room and was so sad, I totally shed a tear. And I remember I have the same birthday as this patient, so I always think of her on my birthday. But, being that person that the family member hugged and said, "Thank you so much for helping us get to this point, and I know my loved one is now leaving us in comfort and in peace and without pain or worry," that was a great feeling.
One of my biggest hopes for medicine concerning serious illness is that palliative care gains more recognition in the field and is able to live to its fullest potential to help patients.
It's important to have these conversations because we have the power to go ahead and do something that might be not what the patient wants.
The reason why I'm doing what I'm doing is in order to share love with my patients and their families and to foster peace within times of illness and vulnerability.
I think medical school does a very good job of teaching us to act, to treat. But the interesting thing is to do no harm is actually our role, right? So shouldn't we have more education and experience on doing no harm?
Stand up, guys. so much hope that they see the problem and they're tackling it with such enthusiasm and depth and commitment. And so thank you all. I'm also happy to report that we have a similar initiative going in nursing schools across the state, and we've got a few nursing leaders here with us today. So if you would stand up and be recognized for the work that we're just beginning, but thank you so much. In a very similar way, we're finding that nurses are often on the front lines of care and yet don't feel quite as comfortable as they want to be in having these conversations about serious illness. So again, I'm very excited to be convening and working with the nurse leaders across the state. We also have another innovative program underway in community health centers. And the reason I think this is so important is the data that Atul was showing us shows the disparity gaps across the state, that people of ethnic minorities, that males, that younger people don't tend to have these conversations as easily as some others do. So we're really excited to get the community health centers together. Many of them are here today, and I think that that's really going to help us to accelerate closing that gap that is so critical for us across the state. And finally, there's some new work to report among our partners in the faith community. As with medical schools and nursing schools, we're in the process of engaging leaders from divinity schools across the state to begin to think about what their role can be. In so many cases, in so many communities, it's the divinity leaders who people reach out to when they find out that they've got a serious illness. And so getting them into the same situation, the same idea of skill and effective and empathetic care, you'd think it would be natural, but what we're finding is that they are learning as well. I want to acknowledge two people and have them stand up. Rosemary Lloyd from the Conversation Project, who's been an amazing leader. Rosemary here. In her work has been to convene these divinity schools and begin to help us work on this curriculum. And Reverend Gloria White-Hammond, co-pastor, if you would stand up, Gloria, for her work in training health leaders. As you might know, Gloria was trained as a physician, and so she brings both the clinical side and the divinity work together, and so is a perfect inspiration for us here. What they have been doing is developing a curriculum that I think is really an important thing. It's they're calling it Sacred Conversations, and they're bringing divinity leaders together to talk about their own personal experiences, and through their own personal experiences, begin to develop a way to teach all divinity leaders across the state how to have these conversations comfortably in care at the end of life. So we're going to show you now a video that talks about the Sacred Conversations work.
When I think about working with members of my church on end-of-life issues, I think of times where I feel we've been able to walk together. There are also times when I feel I haven't been able to do that well, and that's why I wanted some help. There was a recent occasion when a beloved person in the church was facing a very serious illness. I was concerned because initially, he, being such a gentle soul, wasn't really being a very good advocate for himself. I thought my job was to help him advocate for himself, to see himself as a child of God worthy of advocacy. I didn't really let it go. And upon looking back on it, he had already turned that corner. And what I had failed to do was to really listen. During the training, one of the doctors who was working with us, after hearing my story that I hadn't listened particularly well before, she had me engage in an exercise. It was simply to sit there for 2 minutes, 3 minutes, sit there, listen to the person across me, sit there silently for 2 minutes. It was hard.
The mother of my children developed breast cancer, and that was right around the time that I actually went into the ministry. My wife, when she passed, she was Bethel's first death. I just remember all that I went through during that time. I realized the fact that this is more than just somebody being sick. It's a group thing, it's a family thing. And I think that's what the church is about. The church is about supporting each other and being there for people in sickness and in health. One of the issues that you find is, as ministers, we're not trained to share those things with one another. In the training is to sit there with a lot of people saying the same thing. They're asking questions that are on your mind that you don't ask. Anytime you can get together with people of like mind, that was strengthening for me.
I was a young mom at Mass General having a miscarriage and devastated. There was a Catholic nun chaplain that ministered to me. She was so kind and so compassionate that I began to cry a little bit with her. And I said, wait, I don't want to cry. And she said, why not? And I said, well, I'm afraid that they'll medicate me then during this procedure. And I remember her words to this day. She said, Julie, tell them that you want to be medicated only for physical pain, but not emotional pain. And I instantly bonded with her. And I remember later saying, I want to be that for people. Training for this type of work is important because you can think you're doing God's work and not be doing God's work. And so you need another voice to help you discern that.
One of my earliest experiences of a little girl named Elizabeth who I took care of in my second year of residency. She was 5 years old and developed a leukemia for which we, at the time, had no cure. After several months of being treated, she and her mother agreed to stop the treatments and decided that they would return home to upstate Maine where and just live out whatever time they had. After several months, I discovered her in her room having a party. And she explained to me that they were having a party because, as she said, she had been praying. God told her that 3 things. She was going to go to heaven, and she was going to see her grandmother, and she wasn't going to be sick anymore. And the next time I heard from her family, her mother came to the hospital and said, it had a black Raggedy Ann doll, which she had named Dr. Gloria. And before she died, she made out a will and willed Dr. Gloria to me. It's one of those situations where there really was, just this kind of seamless complexity of body, mind, spirit. I had an opportunity to participate in the palliative care education program. And there they presented the Serious Illness Conversation Guide. It occurred to me that some of those same questions are ones that a community-based clergy would be concerned in terms of supporting their congregate.
So what do I hope comes from training of people with faith? I think it's a willingness to maybe go into deeper waters.
Part of journeying with people is to be with them in times of great sorrow and pain, and know it's not ours to fix.
So I hope people begin to look at the fact that they're more than flesh and blood. And I want people to begin to think about that, and the legacy that they're going to leave and how they want to do it.
I think one of the things I'm hoping that we can learn too is the extent to which community-based clergy, working with hospital-based clinicians, can collaborate more effectively around the care of my congregant and your patient.
It's so exciting, the power of collaboration around care. I think you can feel the momentum building here. So thank you to the physicians and the nurses and the students and the divinity leaders and the community health workers as we all come together to make a big difference. It's my great pleasure now to introduce Ellen Goodman, a Pulitzer Prize-winning journalist, an inspiration, a pioneer, and a great friend. Ellen.
Thank you. That was wonderful. That was just a delight. And now that we've all gone so deep, let's go shallow. This is a panel that is really here by popular demand. Last fall, when we asked all of you how the coalition could help in the work that you are doing, the most powerful request that you all had was to talk more and to think more about public outreach and public engagement. So two things were remarkable. First, everyone in the room was a change agent. You know, whether you were inside the healthcare system or outside, everybody here identified as a change agent. That's pretty remarkable. And the other thing that was remarkable is the questions that all of you asked. The question was not, can we change the way people are living with serious illness? The question was, what will it take? Not how, not whether, but how. And that's no small thing. In fact, this morning we've already heard two different messages. The first was from the survey, is that change, real, deep, substantive change, takes time. And while I certainly hope it doesn't take 45 years, which exceeds my predicted lifespan, I am reminded of the wonderful quote from Jack Kerouac, the Beat Generation poet, who once said, "Walking on water wasn't built in a day." The other message came from Jonathan Bush, and that was about the importance of a story, the importance of hearing an alternative, and the importance of individual action. We saw the importance of Barbara Bush's public decision, her decision to go public, really, to share this as her last will and testimony, the decision to control the end of her own life and her family's. And equally compelling to me, at least, was the fact that her family respected all of those wishes. No small thing. So first, I think we can all begin by acknowledging how much the willingness of people to talk about this issue has changed. And Atul mentioned the godforsaken death panels that we all began with not that long ago, 6 or 7 years ago. Since then, there have been books, and there have been movies, and television shows, and columns dedicated to these stories. It's entered the public conversation already. And that said, we also know how much there is left to be done before people's wishes are expressed and respected, before we truly change the cultural norm from not talking about how we want to live with serious illness to talking about it and having those wishes about values at the heart of these decisions. So we're going to spend a few minutes this morning looking at other public health and social issues that were once considered almost impossible to change, and how, in fact, they changed. We're going to look for a few minutes at the success stories. We finally chose to talk about 3 of the success stories and then to bring up 2 of our experts to talk with us more about how these stories apply to the work that we're all doing. The 3 that we chose were smoking, automobile safety, and marriage equality. Big, honking changes. To remind you of what Atul said, the bridge-span notion about what successful campaigns have in common, I'll just do quickly. They build a shared understanding of the problem. They set winnable milestones. They created emotionally compelling messages. They didn't assume a demand for what they could supply. They drove it, and they were flexible. When one message or one approach wasn't working, they embraced a course correction. So these social change had a variety of different strategies. Some were driven by stories, some were driven by grassroots initiatives, some by useful research, some by legal challenges, some by legislation. They all engaged public opinion. None of them would have happened without changes in public attitude. So as we go through these, I hope you will be thinking, both about the importance of the overarching campaigns that we are doing together and our goals, but also the importance of the individual actions and the way in which we can each change our own institutions and behaviors. So, with apologies to Buckminster Fuller, we have to think global and act local. As we have seen both in the way that the women's marches evolved, just as an example, we have an overarching connection between those marches and those pussy hats, but we also have women in multiple districts all over the country knocking on doors and running for office, so we need both of these approaches. So we're going to do great classics in comic form for a few minutes, or speed dating through the social changes. Forgive me if this goes too fast. The first, which Atul started to talk about too, is smoking, and that's probably the one we are the most familiar with. And first of all, I think we should all remember that there was a huge initial campaign to get people smoking, and that was called advertising. And that was all pro-smoking. In World War I, we had these wonderful messages which would keep them smoking. And it wasn't really until 1964 when the Surgeon General's report on smoking changed people's recognition of the dangers of smoking. And the number of people who believed that smoking caused cancer went from 45% to 78% in the years from 1964 to 1978. But the number of people who stopped smoking barely declined. In fact, the tobacco companies promoted a healthier cigarette, which we all remember being promoted by our friendly neighborhood doctor. Then in the 1970s, there was a swerve or a change in tactics from talking exclusively about the dangers to smokers to talking about the dangers of secondhand smoke, from not attacking the smoker, but really the harm to others. And this eventually led also to what we know, as Atul mentioned, smoke-free airlines, restaurants, offices, and yes, hospitals. In fact, by 1992, 500 municipalities across the country had ordinances to protect non-smokers. And each of these was, to a certain extent, an individual action as well as connected to the larger campaigns. The Robert Wood Johnson Foundation, the Campaign for Smoke-Free Kids, all created different but connected campaigns. And then, happily, in 1994, the tobaccos offered all of us this incredible enemy when they came before Congress and in a united panel of CEOs, all denying that smoke was addictive. It really does help to have a nice enemy like that, as that was the end of their credibility. So in 1998, the attorneys general of 46 states won an agreement making tobacco companies pay $206 billion over 25 years for Medicaid-related costs. So the drivers of the smoking campaign were research, health research, PSAs. The Turning Point focused on non-smokers instead of smokers. And it's not over. There's vaping. There are all kinds of sneaky little products directed at kids, like a tobacco vaping product that literally comes with a lollipop. However, in 1965, 42% of Americans smoked. Today, 15% do. So the next campaign we talk about briefly is auto safety only. I'm going to narrow it down a little bit to driving while drinking, because these campaigns were all pretty different. As an example of grassroots action in the anti-drunk driving campaigns, we had Mothers Against Drunk Driving, and they had a powerful emotional message driven by parents who had lost their children. MAD also had focused on legislation. which was lowering the age of drinking and lowering the barrier of impaired drinking, and that was pretty successful. But along with that, there was a second approach too that was launched in 1988 by Jay Winston at the Harvard School of Public Health, who promoted the idea of the designated driver and then disseminated this idea through a powerful joint project with Hollywood, which was unprecedented at the time. They didn't, again, attack alcohol or even the drinker. It just didn't, it offered an alternative cultural norm, the designated driver. And for the first time, a public health campaign got a message inserted into the scripts of top-rated television programs like Cheers. Now, over a 4-year period, 160 prime-time programs incorporated plots. The designated driver became a household phrase. And again, as Zamawa will tell us later, this didn't end the whole story. But it was interesting that there were two different approaches to this. And again, like with tobacco, other problems rise to take its place, like, for example, the designated driving, the distracted driving campaigns. But drunk driving fatalities have been down 64% since 1982. So our third, we are speed dating now, because I can see the little times coming. Our third example is same-sex marriage. Let's remember that same-sex marriage had been outlawed. I mean, if you want to start way back in 342, a Roman emperor said that ordered execution for same-sex marriages. And until 2003, the Supreme Court decision that said sex between homosexual partners, it had literally been illegal in Texas and 13 other states. So originally, the gay rights movement didn't even think of going for marriage. It spoke in the language of rights. And gradually, several things happened in the aftermath of the AIDS epidemic, the post-Stonewall gay rights movement, the great coming out movement. There was a popular cultural change with shows like Will and Grace. There were a huge number of gay people who simply came out and became known, and everybody suddenly knew that they knew someone or someone in their family, even in Dick Cheney's family. Nevertheless, there was also a lot of failure and a lot of half measures. There was don't ask, don't tell, and laws in some states explicitly outlawing marriage, and there was, of course, backlash as well. Finally, there was a commitment on the part of gay movements to go for the goal of marriage. This was not at all uncomplicated for everybody in that movement. So how did it switch from a campaign for same-sex marriage, let alone to the successful campaign? When marriage was cast as a right in the public conversation, it frankly appealed to a smaller part of the population. So one turning point was the dismal electoral failure in 2008 when the statewide proposition in California lost. And so the gay rights movement began to change its message. The public messaging went from a message about equal rights to a message about love, about relationships, about family. In a sense, this was a very conservative message, but one that could reach out to an empathetic level and one that people could relate to. There were many other tactics as well. There was legislation. There were Supreme Court cases, as we all know. But before the Supreme Court decision, from the year 2002 to the year 2014, there was actually a strong flip in public attitudes. We went from 37% of the public approving gay marriage to 59%. That was, again, the courage of individuals coming out of the closet. It was businesses that decided to support gay marriage. It took individual action and many companies as well supporting gay marriage. So to summarize all of these campaigns, since I am a minute over and I am now talking as fast as I can, it's like going to that 1x on your podcast. All of them took a long time. All of them had a strong component of changing public attitudes. All of them had goals, and all of them were pretty flexible in terms of messaging, and all of them had several approaches simultaneously. There wasn't a single magic bullet. They seemed to have one or more big campaigns and then a huge number of individual people in their own organizations, their own buildings, whether they put up a no smoking sign or came out to their families or became a designated driver themselves. It was all over. So each in his or her own way found a way to be part of it and to do their own thing. So I think that today, I hope that we can, forgot one of my, so I think that we can all, I hope, think global, and act local. We've agreed on a set of goals, but we have to each think about what we can do best in our own workplaces. We have to think about what kind of water we can build. And this is the point at which, happily, I turn to our experts and bring them up onto the stage to join us in a conversation about what we can all do as we think about our own individual actions in the context of our huge campaign. So please come up and I will. So.
Get that laugh for you.
Okay. Thank you. So our first, we have two people with us today who are experts in this field, and one of them is Zamawa Arenas, a 5-time Emmy Award winner, marketing strategist and entrepreneur intent on making a difference. She's the founder and CEO of Flowatech, a brand marketing consultancy that helps socially responsible leaders grow their startup or social enterprise. Our second one is Sandro Galea, and Dean of the BU School of Public Health and an epidemiologist, and he previously held academic leadership positions at Columbia, University of Michigan, and his scholarship has been at the intersection of social and psychiatric epidemiologists. So we're going to ask Zamawa first to talk to us, and then we're going to talk with each other. Are you on?
I should be. Can you hear me? Is that better? Let's try that again. Thank you. And thank you for inviting me to be part of this conversation this morning. I'm very thankful to be here because part of my career I've spent in developing campaigns and public outreach efforts around some of these issues, tobacco control, drunk driving, and this is a very relevant conversation for us to have. But also on the personal note, my 95-year-old mother-in-law has been revolving through the nursing home and the hospital for the past month and a half. And during this time, she actually brought up the point that, isn't there a small pill I can take so I don't have to wake up in the morning? And that to me has been very striking in how we navigate through this experience. And it's really become, living for her has become a lot about dying and what that means to her as an individual and how we cope with that as a family. So I'm very glad to be here and be part of this. I'm learning so much from all of the conversations. So I wanted to open up with some remarks around this work to share what I think are 3 lessons from the examples that we just saw that are relevant to the work that you're trying to do with serious illness and advanced care planning. And the first one is that the general public is not an audience. And what we learned through these efforts of tobacco control and drunk driving is that we can't speak to the public in the same way, and that there are different attitudes and likelihoods of people changing behavior based on their motivation to change and where they are on that spectrum. When we were working on tobacco back in the 90s, 98, 99, it wasn't just about targeting all smokers equally. It was about thinking about a spectrum of behavior and where people fell in that spectrum, from those who were completely tuned out, who would never change, who would never quit, to those who were contemplating and perhaps thinking about this behavior and adopting the behavior, and those who were ready to quit. And really, it became about targeting those who were contemplating. That was the big percentage, and making sure that we were moving them across a spectrum of behavior change to really then bring others along. And in looking at some of the research that you had done in the surveys, it was really interesting to see that about 50% of people have not had the conversation but would want to have the conversation. To me, that's an opportunity target. I think that's encouraging that we have 50% of people who are interested. To me, those are the contemplators. And we just need to move them along that spectrum. So doing this work really requires segmenting the audience. Who are we talking to? What are their motivations and what are their attitudes? Because behavior change is a journey. It's not one single event. And people will change behavior not only rationally, because we can all rationalize the behavior, but it's when we feel it in our gut and in our heart that we start moving and we start changing our attitudes and behaviors. The second lesson I would say is that words matter. And words tend to trigger mental traps and biases in people. It's inevitable. And the example of Barbara Bush saying compassionate or comfort care versus palliative care, because that resonated with her more closely, it's a way of how language really affects how we react to things. So when we talk about end-of-life care, what does that mean? What does that imply for me today? And we saw also in the survey that you have about 70-something% of people who have said that they don't have the conversation because they're healthy, they're not sick, so why should I have it now? And I think that has to do with language and some of the mental traps that we have and that we have to overcome. And to do that, it's really about persuading people with messages that are relevant to their lived realities. What does it mean for me? What does this language mean? And how can we make a much more personal connection and emotional connection about the benefit? Because when we change behaviors, we're giving up something. There's a price to pay, and it's not unlike commercial marketing, where you buy a product, you pay a price. The product we're selling here is advanced care planning. We have to pay a price as individuals to adopt that. What is that? Is that denial? Is that inconvenience? Is that a lifestyle change? What is that? Can we appeal to that feeling and make the product worth that price? And lastly, I would say that all of these examples we saw required a consistent, coordinated effort. And it was a group of people who owned these efforts. But they also required money, lots of money, and stick-to-itness. And we've seen 20 plus years, 40 years of work. And when we look at the work around tobacco and drunk driving and marriage equality, all of these efforts required also grassroots advocacy in some shape or form. So grassroots advocacy also helps drive the conversation because it can tap into public sentiment. When I say they require money, I can say, for example, that in '98, the tobacco control program had a budget of $14 million a year just for their public education efforts. And that included grassroots organizing and media campaigns. Last year, working with the Executive Office of Public Safety and Security, the budget was $2 million to create campaigns to get people to not drink and drive or drive distracted. So funding and resources matter because of scale and having that impact. And I'm not saying you need $14 million, but I'm saying the funding and resources are also part of the consideration. And it's not in the bridge span equation, but it's embedded in every single aspect of that diagram. There's funding that fuels all of that work. So I think that there's a great opportunity because the data is showing that people have a tendency to think about this. They just need the extra push, and they need that extra push with the messaging that's compelling to them, that is about value, that is about benefit, and that can drive them to take that small step, because it takes small decisions and small actions until you actually change. So thank you. Thank you.
Sandro, thank you.
So thank you. Is this
yeah.
Seem to be on, maybe higher. Thank you for having me, and thank you, Zamawa. So I'll also try to make 3 points in the spirit of advancing the conversation. And I'll start the first point around changing the narrative. And I think, Zamawa, you made a really nice point about there is no one audience. There are multiple audiences. But I want to highlight 2 aspects which I think are important about changing the narrative. Number one is changing the narrative ultimately is about taking something that was invisible and making it visible. So you talked about advanced care planning. And at core, it's about making it clear that this is something that we want. It needs to be part of the conversation. It is part of the creating demand. So the narrative has to come from multiple different angles, from multiple different people who are telling stories, who are producing data. That's all part of the narrative. The second part of changing the narrative, if I may borrow from 1958, none of this is actually new. Sir Jeffrey Vickers had a formulation for what public health does, which I really find useful, which is ultimately to improve health, we need to take what's acceptable and make it unacceptable. And I think one could say that not having advanced care planning, not thinking about serious illness care, is unacceptable. Now, there are many things that we used to find acceptable that we no longer find, that are no longer acceptable. So, for example, 150 years ago, it was acceptable that you had children dying from various preventable, communicable diseases. Now we would find it unacceptable. But there are things today that we find acceptable that in 150 years, people will be shocked that we found acceptable. Like we consider it acceptable, for example, that the majority of people in our prison system have mental illness. Right? That should not be acceptable. I think we all know that. I'm just using that by way of example because, so we don't sort of get too pleased with ourselves. There are a lot of things that we actually do that should be unacceptable. Now, we're focusing on this one issue today, but I actually think changing the narrative is to really build on Jeffrey Vickers from really 7 years ago. Take something, make it clear that it's unacceptable. Make clear that it's acceptable, it should be unacceptable. And we saw that in smoking, right? And we saw that as well in marriage equality. And we changed the narrative around it. Now, how do you change the narrative? Well, there are many audiences, there are many segments, and I'm going to come back to this at the end. I actually think it requires 1,000 narratives, not one narrative. So point A, changing the narrative. Point B, this requires patience. Any large change requires patience. This is the 3rd meeting of this coalition. And unfortunately, we have a shockingly short lifespan. That is the truth. And you're like 3 years, okay. 3 years, I should see some change. But change happens over 20 years, 30 years, 40 years, 50 years. And even more frustratingly, change is discontinuous. Right? When we think about change, we like to see graphs that do this or do this, depending on your direction. Right? We like to see progress every year. But that's not really how it happens. It's actually discontinuous. What happens is this for a frustratingly long period of time, and then something happens. Just use one example. It's not the 3 examples that we illustrated here. We can talk about the Me Too movement. I mean, that is a perfect example. I mean, the Me Too movement is not built on anything new. I mean, sexual misconduct has always been unacceptable, right? But for decades, there's been no progress, and then something totally unexpected happens, and the whole conversation changes. From my perspective as dean of a school, I have many faculty in the school who've done work on sexual abuse for decades, completely ignored by the media for decades. All of a sudden, they're like getting full-page spreads in the Wall Street Journal, who says, wow, look at this great work you're doing. Well, they were doing that great work in 2002, but nobody paid attention to it. But I think that's okay. I'm not saying that I'm not saying it in a way that begrudges it. I think it's okay, but I think when one is building a coalition like you're all doing here, it requires that patience over time. When you're like year after year, and you say, geez, nothing's happening, because something will happen eventually. So point B is about patience and discontinuities. And point C is about action at all levels. I like the Bridgespan formulation very much. My only concern with it is that it might imply that broad social change can all be organized and coordinated centrally. And experience teaches that's not the case. It's not the case in drunk driving, it's not the case around marriage equality, it's not the case around smoking. It actually requires, yes, clarity about something that is better. Does this mean you've only heard every other word I've said? Wow. Well, the words you did not hear were the best ones. So thank you. Where was I? Oh yeah, action level.
Clarity.
Clarity. Yeah. So So yes,
You're in clarity, which is perfect.
we do need to make sure. We do need to make sure that we are clear about what we're trying to make unacceptable. But at the end of the day, it requires action at all levels. I mean, when we saw the graphs around smoking, what we didn't hear about is about all the CEOs who made smoking unacceptable in their hospitals, in their companies. What we didn't hear about is about all the individual CEOs who made sure that there were equal rights for same-sex partners. What we didn't hear about is about the individual people who are producing data and who are writing, frequently falling on deaf ears. And then all of that eventually came together, and all of that eventually results in social change. Now that's a bit frustrating, right? It's a bit frustrating because if you're a CEO of a company and you're like, you know, I'm making sure that there are same-sex marriage benefits. A, nobody pays attention to you. You don't get any kudos for it. B, you're probably getting a bunch of flack from people inside your company, and you're doing it with the right thing. And there is no broad social movement to protect you. You know, I always find it a little bit cynical when there's a broad social movement. All of a sudden, everybody's doing it, and then like people stand up and say, "Look at the great thing I'm doing." Well, okay, well, it's very nice, but now everybody's doing it. It's easy to do. Really, the heroes are the people who are doing this before it's actually part of a broad social movement. So I do think that at core, these changes, what the history of public health teaches us, and I speak from the sort of place of public health, is that it requires action on behalf of many, many people in many, many different sectors. So the challenge that I always pose, I try to pose for myself, I try to pose it for our students, try to pose it for my colleagues, is what is it that you can do given your platform, given where you sit, given your domain of influence? And I think it's hard because one feels like, well, my domain of influence is actually pretty small. That's okay. That's okay, because ultimately the bigger domain of influence is constructed by multiple small domains of influence. I think the individual hospital, the individual community health center, the individual private company, all of those can do particular things, different things, towards the broader vision. So to summarize, number one, narrative overall, making the acceptable unacceptable. Number two, patience and discontinuities. And number three, action at all levels. I'll stop there.
Great. Thank you. I think we are very aware and that's a good reminder that everyone here has about the relationship between the work we are doing together and the goals that we share and the way in which everybody's own individual actions in their own workplaces and their own institutions do make a huge difference and add to it. I'm curious about one thing, and I'm also curious about the $14 million. We'll go back to that. But I'm curious about whether you think that the subject that we're dealing with, which is death, comes with its own particular problems for messaging that the other examples that we have talked about don't really come. And I think we should share this because the little lapel mics aren't so great.
I do think it poses some very particular challenges because talking about death is something that not everyone wants to do, and serious illness makes us confront our own mortality, and that in itself is challenging. So I think it's really a very particular issue to this cause, but it's not insurmountable. And we can see that, as we've seen in other public health efforts, that when we start making the behavior the norm and not the exception, more and more people are going to come along. And that happened with tobacco, that happened with marriage equality, and that happens in a lot of different contexts. And I think that what's happening in this context is also related to language and how we're talking about this issue and how we talk about death and how we make it less daunting for people to have this conversation and really focus on smaller steps and small actions that you can take and make that be about the benefit that is what you will gain from that action.
Yeah, I think death is icky. We don't like talking about death, but I think much of social change is about icky topics and things that today we consider normative. They didn't used to be. I mean, a perfect example, perhaps, in a healthcare crowd is probably the biggest single thing that reduced mortality within the healthcare arena is hand washing. And the original data about hand washing comes from Ignaz Semmelweis, who showed that doctors who are not washing their hands and going from autopsies to dealing with mothers giving birth were killing those mothers, while nurses were washing their hands and they were not. Now you think that he would be lauded, but no. In fact, Ignaz Semmelweis was discarded in his time, neglected in his time. He died poor and actually in a mental institution because nobody wanted to talk about hand washing. Now we're all sitting here thinking, how could you not want to talk about hand washing? Well, we did not 150 years ago. So I think death poses challenges, but I would defer to my colleagues in marketing like Zamawa to figure out how to make death cool. And I mean, stranger things have happened, and I think we have the advantage. We have the advantage that unless you believe Time Magazine, who says we're going to live forever, which by the way is nonsense. We're not going to live forever. We just need to accept the fact that it's a universal experience, and might as well deal with it. And that's the narrative that we need to get out there.
And Zamawa, I'm interested too. You were talking and looking at the statistics, and you were saying, if I am not misinterpreting you, that you focus on the lower hanging fruit, you focus on the people who are more amenable. Now we have some, or more likely to come along to create, is that what you're saying? Because at the same time, we have so many demographic differences, and do we need to create separate messages for that, or do we need to go with the people who are most likely to take on the message?
I would say it's both. I think you have
I was afraid you were going to say that.
I'm sorry. But I think you have to apply multiple strategies, and there's not one strategy that works for all. So in moving the needle, there is a percentage of people who are more inclined to take action and have the conversation and do advanced care planning. We need to know who they are. What are their demographics? What are their psychographics? What are their profiles? And then we can find people like them. And now with the advent of social media and digital marketing, it's so much easier to find people who fit a certain attitude. So in that regard, that's one strategy that can be very effective because it can move the needle a little bit more quickly. But then you have other groups that are not engaged that would probably want to be engaged, like diverse communities, people from other countries with different immigrant backgrounds. And what we need to know is who are they, what are their attitudes, what are their behaviors around this issue, so we can craft strategies and messages that resonate with them. So it's not one single bullet, there's not one single way to do this. There have to be a lot of thought about who the audience is and how we reach them with the right message. Because culturally, I come from Venezuela where you don't even talk about death. And that is a cultural bias that people have. You just don't want to talk about it. And you don't even talk about wishes because you expect that your doctors are going to know what you want. So that there's a cultural attitude there that can be addressed with the right messaging and the right understanding.
Let me just add one thing to that, which is I would take it from the perspective of the we. So you said, should we do the following? And I guess my question is, who is the we? And this goes to the point I was making, the third point I was making. The we, for something that is as big as this, the we is a really coalition of us. And I think different members of us have different capacity to reach different audiences. And I think, yes, at a level of a coordinated political campaign, there is one message that is going out there because it has a very specific end. But this requires every single person who cares about this issue to push forward the message from their platform. And I think different people have access to different audiences. So I guess my encouragement would be for everybody to think carefully about what is the audience that I can reach, and then what does that audience need? Because I think it's messier than having a single coordinated message and a single sort of segmented group, because ultimately you're trying to build a coalition towards changing how we think, and that's more complicated than selling something or selling someone.
I'm interested in your talking about different messages. We have people who are working on this inside the healthcare system, and we have people who are working on it in a more public-facing way. And we've talked a little bit about it, the double helix of social change, meaning comparing end of life with the birth movement and how people changed the way we give birth in this country. And it wasn't doctors in the institutions who changed it, but it was women and families coming from the outside saying, you know, it wasn't doctors who said, bring the video camera, let's have the baby in a bathtub, you know, get your feet out of stirrups. It was women and families outside of it, and then the institutions changed too and encouraged public changes as well. I'm interested here because we are people who work inside the healthcare system and outside of it. How you see those two different constituencies both changing and staying in connection with each other.
Do you want to, why don't you start? I always start.
She's outside, he's inside.
Well, I think as individual institutions, you're all vehicles for social change. And I think of this as social change. It's not just a public health issue. This is a social norming effort. And from the outside, I think it's the individuals who need to start creating demand for this kind of behavior that can also impact how doctors and providers and professionals have this kind of conversation. And from the data that you showed in some of your surveys, it indicated that having the providers initiate the conversation was not something that was stressful for people. So it seemed like there's an openness to have action from within institutions to help you have that conversation. So I think that creates an opportunity for all of us here, or institutions, to proactively figure out what role they have in creating this social change and driving the conversations from within, and not just waiting for the conversations to start from the public or from the outside.
And I think it's also the question you raised about starting the conversation seems to be the hurdle that everybody has to get over.
Right.
When we did a survey at the Conversation Project last year and repeated it, it basically said that 90% of Americans know it's important to have these conversations, which is it's everybody. But only 27 and now I think 32% have actually had them, and closing that gap. And one of the biggest impediments that people said was it's too soon. But really what they were saying is, I don't know how to start that. And starting it, what's your feeling about starting it with outside of the system, with families, with the people you love, and then bringing it into your medical establishment versus having the doctor initiate? It seems like doctors are more comfortable when people initiate, and maybe people are more comfortable when doctors do, and maybe nobody's comfortable initiating.
Well, I'll take it from a point of view. I don't think a doctor is a doctor is a doctor, and I don't think a patient is a patient is a patient. I think we're heterogeneous. If the study of system science teaches you anything, is that we are humans are fairly heterogeneous agents. We behave differently, and doctors behave differently. Whenever I speak to medical students are typically motivated by the right reasons when they go into medical school. Then things happen. But
medical school happens. Is that what you're saying?
I'm going to leave it at that. But I frequently get medical students who say, "Well, what can I do?" And I think that's actually a very personal question. I think the job of a coalition like this one is to make something that's invisible, make it visible, to move the narrative towards changing, to make something that's acceptable, make it unacceptable. But ultimately, all of that has to sit, as I said earlier, on this base of action at multiple levels. I think some physicians are going to be comfortable initiating conversation with patients, and in some cases, patients are going to be comfortable initiating with physicians. And ultimately, we need to achieve broad change. We need to work at both levels, because we don't know whether a tipping point is going to arise from the inside or from the outside. And maybe it'll be at the same time, unlikely not. Probably what will happen is years of pushing and pushing, nothing really changes, and then a discontinuity happens, be it from the inside or from the outside. But the work has to be done on both sides of the ledger. That's from my perspective.
Yes, I'm curious, because it seems to me that the gay marriage movement was an unbelievably fast change, even though the gay rights movement was far more than 45 years. But that moment at which marriage became the goal to the moment at which it was achieved was way faster than almost anything I remember seeing in covering social change.
Well, I'll give a perspective, then I'll pass it over. I don't think it felt very quick change for those who were working on it for 40 years. I think it burst into consciousness, and there was sort of this rapid change, but it built on decades of work. Let me add a wrinkle to this, if I may. It is something which I struggle with. There is such a thing as change that's too rapid for broad societal changes, and there is such a thing as particularly legislative change that happens sometimes, which there isn't a broad enough base of support for it. And we've seen it in a couple of cases over the past few decades. And I think that's tricky. Because I think anybody who's interested in social change to improve health, let me just use the term, sometimes wishes for a magic wand, and wishes for a politician, say, to lead, which is of course not the case. Usually politicians are following where the social winds are going. But having a legislative change imposed without having the broad base of support and readiness for it, I think poses its own other world of problems. So I just wanted to label it so it's out there in this conversation.
And I would add that Marriage Equality USA had a base of 400,000 members. It was a very strong grassroots effort. They were very organized, they were very active, and the big change happened when they changed the discourse from same-sex marriage to marriage equality. And that was the tipping point for them. But one of the key things they did too was that they protected the legislators, because when legislators voted in favor of marriage equality, some of them paid the price of not winning again an election or being pushed out of office. So having also a strategy on legislation and how you protect legislators who support your cause was a winning strategy for marriage equality. And they learned that lesson hard when in Hawaii it was passed, and then they changed and amended the Constitution to prohibit same-sex marriage. So then they were learning as they went, and they did a lot of message testing. They iterated their messages constantly. So it really galvanized all of these 400,000 people to be behind this effort. And I think maybe that's when you see the pickup and the speed, but this was going on for many years. And to get to that size of coalition, it took a lot of effort and a lot of years.
So let me bring this home to our group, since we just have a few more minutes, and ask you very directly what individuals should do and how the coalition can help support individual action.
You want to go?
She passes the baton.
All right. Well, I think the change starts within each individual institution, in each individual here in the room, and I wonder how many people within each one of these organizations has named a healthcare proxy, has had ongoing conversations with their healthcare proxy. Do we know? Are we tracking that? Are we making that part of our individual commitment to make sure that we're living up to the values that we're promoting and that we're leading by example? So I think we are all individuals, and we have a multiplier effect that transcends our organizations internally to have an effect externally as individuals. So I would say each individual organization has a role to play within the individuals that work and operate in them.
So I think, as you can expect from my comments, I agree with that completely. I actually think that's exactly right. And let me answer then the second part, which is what can a coalition do? Well, I think a coalition can do two things. Number one is the larger group can act at the broader level of narrative change. It can try to seed the next will and grace. That's hard for individuals to do, right? So I think the coalition can work at the larger levels of narrative change, which individuals can do, number one. Number two, I think coalition is essential to provide individual with resources, to provide individual with the resources that she can use to make change in her local context. And we're seeing that right now in multiple social movements. I mean, one very good example that's happening right now in this country is around firearms, the intractable issue around firearms. And you're seeing a number of coalitions, and what they're doing is they are providing resources for local change. So I think a coalition is essential because the individual ultimately left to her own devices will be enterprising or not, but a coalition can do this. So I think the coalition can do those things, but at the end of the day, I agree completely that the real action has to happen in everybody's individual sphere, the individual CEO, the individual hospital, the individual community health center.
Well, I want to thank you very much for your help. I think we will take your messages to heart, both as a coalition and as members of of each individual organization, and appreciate your help very much. We're about to go for our lunch break. You'll all be happy to know. But before we do, we have one video to send you off, hopefully laughing and thinking, that we will share with you all. Whoops.
Be your healthcare proxy? Like if you need someone to tell the doctor what to? I just go with whatever the doctors say. I wouldn't want to bother them. They're so busy. Doctors know.
I'm sorry, I didn't introduce it. This is a video that the Conversation Project did for National Healthcare Decision Day, and it's basically to encourage proxies and to help you know who's a good proxy and who's a bad proxy, and this is your attempt to, this is our attempt to help you make those decisions and then go have lunch.
Be your healthcare proxy? Like if you need someone to tell the doctor what to? I just go with whatever the doctors say. I wouldn't want to bother them. They're so busy. Doctors know best, right?
Be your healthcare proxy? Sure, I'd be happy to. If I'm in town, check out my Instagram pics from Peru. Wish you were here.
Oh, I could never let you go. I can't even throw a plant away. As long as it's got one little green leaf. I'd be like, can't we upload her to the cloud?
Well, heck yeah. I've given this a lot of thought. Let me tell you what decisions you're best off going with. You never let them resuscitate you. And if they even try to hook you up to one of those breathing machines, never. I got this. I totally got this.
How can you even talk about this? I can't, okay? I just can't. Mom, it's not like you're gonna die. No, I can't talk right now.
Oh wait, did I show you that meme from iFunny? The cat and the dishwasher? Oh my gosh, okay. So the cat's like, bleh. And then he's like, wah! Oh wait, sorry, what?
Well, hon, you and I have been through so much together. Here's what we'll do. We'll sit down, we'll get a cup of coffee, and you tell me what matters to you.
Well, it wouldn't be easy. I mean, I'd be sad, but I'd have your back.
I remember when we went through this with Mom, we really spoke for her. So I think I can do that for you. Let's talk about what you would want.
I lied. There's one more thing before you go to lunch. We want to say thank you to all of our faith leaders who we didn't have a chance to say thank you. Would you all please rise so we can thank you? Thank you all, and go have lunch.